So HIPAA, Health Insurance Portability and Accountability Act, so everyone has to be familiar with that. So when you are in intraoperative monitoring, so you have access to the patient information, private information, and which can be electronic, written, oral communication. So you have to be familiar with all the rules and laws of that, and you cannot be disclosing that information or using that information, or cannot access the patient which you are not part of that. So that's a different legal and have serious repercussion if you are not familiar with that. So let's go to the application of the intraoperative monitoring. So neurosurgery, in the neurosurgery, so there are different types of neurosurgery where we can use neuro monitoring, which could be brain surgeries, could be brainstem, could be spinal cord and peripheral. So the nervous system, from brain to the peripheral nerves, any part where this different type of surgery is being performed, so we can use the neuro monitoring and make sure the neurons passing to that, either the sensory, motor, auditory or visual, they are all okay, and we can do different techniques to do that. So it could be brain tumor, spinal cord tumor, peripheral nerve tumor, microvascular decompression, spinal cord fusions, or peripheral nerve tumors, so anything. And then we have orthopedic surgery, so any kind of orthopedic surgery where the nerve is at risk, so such as spine procedures, scoliosis procedure, trauma, fractures, hip surgeries, tibial osteotomy, fibular osteotomy, shoulder surgeries, minimal invasive surgeries. So all these surgeries, the nerves, there are different nerves at risk. So like for shoulder surgeries, you have median nerve, radial nerve, musculocutaneous, axially, all these nerves are at risk. So we can monitor all these multiple nerves to make sure the nerves are not damaged. So same as hip surgeries, with the total hip replacement or acetabular surgeries or sacroiliac joint, so these nervous system at lumbosacral area, they are at risk. So we can monitor all femoral nerves, postperoneal nerve, fibular nerve, tibial nerve or pudendal nerve, sensory and motor function, saphenous nerve also, to make sure it's a big setup, need a lot of training, but it can help the surgery to be more aggressive and do more better surgical manipulation and know the limit, where to stop and where the distraction can cause changes, and you can stop them. ENT surgery, parotid tumors, thyroid tumors, facial nerve tumors, cochlear implant, so all these surgeries around the ear, nose and throat, that can also be monitored by different types of modalities. Cardiovascular surgery such as coronary artery bypass, grafting, carotid endarterectomy, aortic aneurysm repair, aortic and so abdominal aneurysms or thoracic aneurysm. So all these surgeries can be monitored, which can be very, very dangerous for the spinal cord, because spinal cord can be ischemic during these surgical procedures and can result in total paralysis post-operatively. And then we have general surgeries, some nephrology. So if there's a big tumor in the source major or prostate surgeries or colorectal surgeries, or even hysterectomy, patient with hysterectomy, they have post-operative, up to 50% have post-operative neurogenic bladder. So we can monitor those structures and minimize those damage. So what I'm trying to do is just going to give you like a brief 50,000 feet overview of what is neuromonitoring, and in this presentation, and what are the different objectives or the things you need to know to learn that. So what are the working in the operating room, what are the daily tasks, the skills needed to work in this field, different type of education and training required, what are the certification, the work timing. And so I try to be very, very, because the limit of time, so I can not go into more detail, but just going to give you some of the information. So the daily tasks, so you have to go and talk to the patient every time before the surgery. Some hospital may not allow you to attend or talk to the patient, but it's always recommended to talk to the patient, get the patient consent signed, take the patient history and make sure there are so many different patient has preoperative diseases, hypertension, diabetes, multiple sclerosis, cerebral palsy, so and hearing deficit, visual deficit that can affect our intraoperative signal. So it's always important to get that information before the surgery so we can do accurate neuromonitoring. And also get the consent and have that information available to talk to the surgeon and anesthesia according to that. So and then during the surgery we recorded electrical signals during the surgery, and the neurologist is interpreting the data, and you are communicating, informing the neurologist and the surgeon during the surgery. And at the end of the surgery you have to take out the electrodes and clean the equipment and make sure that all the reports are uploaded on the computer servers. So the required skills, we need to have a very good communication skills so we can communicate, especially when in the operating room where very stressful environment, the surgeons working very seriously on the brain or brainstem, and their team focus, and there are a lot of people talking at the same time. So you have to, and then you have a mask on, and so communicating with the surgeon with loud and clear voice, and also with anesthesia, because sometimes the changes are due to anesthesia, and so we have to know what is the anesthesia. So if there's a changes due to anesthesia, we think that, so we inform the anesthesia and communicating with that. So technical skills, troubleshooting skills are critical because you need to know, like you're working on computer, you need to have good understanding of the computer software and programming. Not see coding, so you don't need the coding, but because the protocol has critical. So if you know that, so how to operate on the computer. Good analytical thinking skills, because you have to analyze the data. Even though you have a neurologist or neurophysiologist online, you still need to analyze the data and inform them that what's going on, if there's a changes. So you have to be very quick in the response, so you cannot wait for too long. So you should be able to work independently. So you have working in the team, you are working in team environment, but you are responsible for your own computer and monitoring data. So you should be able to work alone without any help, having the second person present every time you are in there. You have to be very self-motivated because you need a lot of education. So even you are working, you are in the OR in the morning, and then you work all day, but you still need time to review the next day case, what will be the case, what are the anatomy, physiology, the surgical steps. So it's a continuous learning throughout your career. And then you have to be flexible, because if the surgery is scheduled for 4 hours, it may not end in 4 hours, it may end in like 10 hours. Or the surgery is supposed to start at 1 p.m. and you get a call at 7 a.m. Okay, they're starting at 7 a.m. So you have to run that. So you have to be available, and then you have to know that this can happen, or surgery can get cancelled or moved, and then you have another surgery in a different hospital. And then you need to have a good community skill with working with other people in the operating room. So you have to be working in the operating room, so or interventional suite. So good understanding with the surgeon, anesthesiologist, the nursing team, the neurologist. So these are all critical factors that can help you to do a better job in for every surgery. So you have to arrive at least an hour before the surgery to the hospital, because you need a time to park the car, then take your equipment to the OR, get the biomed check if needed, change to scrubs, go to the OR, set up the table, and everything before 30 minutes before the patient comes in. And because you have to go to the patient before the OR and talk to the patient, get the consent. So it all needs a time, so you have to be very early for every single surgery. And then during the surgery, you have to be in the OR during surgery, so you cannot take a break unless somebody, your colleague or somebody can give you a break, who knows, who's part of the team, and they can look at the data while you're gone officially. So for education, the minimum education associate degree in neuroscience or applied science or degree in neurophysiology, but a bachelor or master or MD, PhD will be much better, because if you don't have a bachelor degree, then you cannot take the certification exam. You have to take another exam, for example, EEGT or REPT, which is exam, and then you qualify for CNIM exam. And if you have MD or PhD, then you can take the board exam. During your training period, so it's most of the time it's on-the-job training. There are few programs now. We have online courses where you can go and attend some courses in order to get to the program, but there are very few selected 1 or 2 courses, or you have to go for a bachelor in neuroscience or bachelor in kinesiology to take a 4-year program, or with the consideration of intraoperative monitoring. But the main focus will be on understanding of the basic instrumentation and electronics of the nervous system, anatomy and physiology of different nervous system, electrophysiology, anesthesia, and different surgical procedure that can be they are under used neuromonitoring. The different certification are REGT, Registered EEG Technologist, and Registered Evoked Potential Technologist, and Registered Nerve Conduction Technologist. So you can take the exam without bachelor degree, but for CNIM you need a bachelor or master, or for IONM you need to have MD or PhD degree. So all the electrodes we are stored in a different, if you are working in a hospital, then you have an area where you can store all the electrodes and supplies. So every time you need, then you can go and easily access them, and then you don't have to worry about not having something in your article. But when you are traveling, so you're going to one hospital, then you need to have enough supply. So typically operating room, you have a surgical table where the patient is lying, and then you have anesthesia machine, and you have X-ray, C-arm, microscope, the other equipment. They all cause interference with the signal. So you have to, and then we have to set up the table where we are not in the field. So the electrodes are placed. So this is not the best way to place the electrodes. So you have to make sure the electrodes, your wires are not hanging on the bed, and they're very good tucked in, so nobody can trip on them, or they can break the wires, or they can injure themselves. So there's legal liability. So make sure we are not doing something like that. So when the patient is in the OR, they are intubated, all the A lines or IV lines are placed, then we can place the electrodes, and making sure that all the electrodes are not in the way of the surgeon. And also have to make sure you are not touching or not near any instrumentation which is used in the operating room. So you have to be at least 18 inches away, and you should never have back toward them. So every time you're passing through that nearby, you have to inform other people, okay, I'm passing, and then you should be 18 inches or more away from the table, surgical table, and then you have to be facing toward the table, so you know you are not close to that. So once you have everything set up, then we collect the data and we start monitoring during surgery. These surgery could be anterior neck surgeries, where they're putting the implants, and it could be spine fusions, could be cervical, thoracic, lumbar fusions, pedicule stimulation, because they're putting screws and all these metal implant, and that can cause, if they break the bone, and they can go into the spinal cord, or they can be not in the spinal cord. They are more medial, but they are touching the nerve roots, so they can cause damage to that. So cranial nerve surgery. So patient with the surgery to the cranial nerves for parotid gland or CPA tumor, everything. So cranial nerves, different cranial nerves are monitored. Patient can be in a sitting position, so you have to know patient will be in a supine position, should be prone position. Patient will be sitting position or lateral position. What will be the position? Because then you have to set up your equipment and your electrode accordingly. So you are not in the way of somebody, and if you need to go and fix anything, so you have access to everything. So brain tumors, thyroid tumors, where thyroid gland resection is done, it could be unilateral or bilateral or total thyroidectomy. Recurrent laryngeal nerve is at risk, and we can use different electrodes, like this is endotracheal tube, which has sometimes it comes with a tube which is attached with the cables, and you can just place anesthesia can put that, or sometimes but they come only on 3 sizes. So if you need a different size, you can use this sticker, which can be placed on any endotracheal tube, and before the patient is intubated by anesthesiologist, and you can plug the connector into your machine and record the recurrent laryngeal nerve during the thyroid, because patient can have loss of voice, hoarseness of voice, or loss of richness of voice during these damage or stretching to the recurrent laryngeal nerve or superior laryngeal nerve, which are branches of vagus nerve. For real-time monitoring, this physician, when we are monitoring, so I prefer to have a place where I can look at the screen, TV screen, if it is in the OR, so I can know what is happening under the microscope. And also the surgeon is looking at the data. The anesthesiologist is also connected in real time to a tele machine. So what is the neuromonitoring? So the purpose of neurophysiology or surgical neurophysiology is to minimize the post-operative deficit, which can be the result of iatrogenic or randomly induced neurological injuries. We want to improve the patient care. We want to reduce the patient neurological deficit. We want to improve the surgical morbidity and mortality. We want to reduce hospital stay and medical cost. We want to reduce overall insurance burden and burden on families, on doctors, which can be very life-changing. So numerous type of surgeries benefit from neuromonitoring, and according to neurosurgery, orthopedic surgery, cardiac, ENT, vascular, and efficacy of IONM has been studied in spinal surgery where significant benefits occur, including reduction of quadriplegia and death. IONM is now considered as standard of care in group and is likely to remain there for foreseeable future. So IONM is standard of care for scoliosis surgery only for right now. It should be for facial nerve and other surgeries, but one of the reasons we are stuck in catch-22 is because we don't have enough people who can monitor that. Because once it's a standard of care, then you cannot do these surgeries without monitoring. So unless we have enough people, it will. But it has proven thousands of research papers published over the last 40 years about benefit of monitoring in spine surgeries, brainstem surgeries. A lot of literature there, which is proof that reduction can be done in different types of surgery, and it's not limited to the only spine surgeries. So the three main benefits of neuromonitoring, if you have to just focus on three main things, will be increased safety of surgical procedure. So any surgical procedure which is done around the nervous system, they are more safe when we are monitoring those nervous systems. And the second one is increased ability to accommodate more complex cases, so that you have very complex case, so you can do different surgery in order to, instead of referring to another center, because there's a high risk of patient deficit. So you don't want to, if you have the neuromonitoring and you are confident with the team, you can accommodate those surgeries in your center. And the third one is decrease the risk of adverse surgical procedures outcomes. So modalities, what is a modality? So modalities are specific type of these neurophysiological tests that are used for specific pathways, such as SSEP, which is one of the used since early 70s, 60s, somatosensory evoked potential, and it is used to protect the sensory pathway or ascending pathway, also known as dorsal column medial lemniscus pathway. So TCEMEP, transcranial electric motor evoked potential, is used for monitoring the descending pathway or motor pathway to monitor the motor tract. SSEP is done for the sensory tract, MEP is done for motor tract. Then we have brainstem auditory evoked potential, or BAEP, also known as ABR, auditory brainstem response, or BAER, brainstem auditory evoked response, and that is done for monitoring the auditory pathway. VEP, or visual evoked potential, is done for any time there's an optic nerve or eye or optic tract is at risk, optic chiasm, for visual pathway. EMG, electromyography, is done by recording from your muscles and for cranial nerves and peripheral nerves, and EEG is done recording from protecting the brain from ischemic or stroke or change of ischemic changes. EEG is done by placing the electrode on the scalp. If you place the electrode directly on the brain, then that will be ECOG, or electrocorticography, and that's directly recording, is more sensitive to brain ischemia. TCD is transcranial Doppler. Transcranial Doppler is done to diagnose any vasospasm or stroke or loss of blood flow or preventing brain ischemia during carotid surgery, different surgeries, so we can see the blood flow. DECS, or direct electrical cortical stimulation, is done by stimulating the brain and identify the motor cortex, face area, hand area, leg area, foot area, and during the surgical procedure, so you're not cutting those areas while the patient has a tumor or aneurysm. Microelectrode recording is done for deep brain stimulation, placing a single recording electrode and then recording. So the first test, the modality. So this is just the overview. So I'm going to go separately in every special modality, but today I'm just going to give it just introducing what are these modalities. So somatosensory evoked potential. So these are stimulated for all 4 limbs. So it's in the left hand, right hand, left foot, and right foot. We mostly left ulnar, right ulnar, or medial nerve, or in the leg. You can do posterior tibial nerve, or you can do peroneal nerve, and then record from peripheral response, like a brachial plexus for upper extremity, brainstem and brain, or popliteal fossa, lumbar aid potential, brainstem and brain for lower extremity, and then we look at those data intraoperatively. Transcranial motor evoked potential is done by stimulating the cortex. So we place the electrode on the scap, and then if it is a spinal cord intramajor tumor, we can place the electrode in the epidural space and record directly from the spinal cord, and that's known as D wave. So we can also record from muscle MEP. So what we do is we are placing the electrode on the cortex, and the signal is traveling down the motor pathway, and we can record the signals, and those signals we are doing continuous interpretation while the surgeon is operating. Electromyography is done by placing the electrode. So here we can see the left leg and the right leg. So on the right side is right quadriceps, tibialis anterior, gastrocnemius, right foot, and right anal sphincter muscles, and the blue is the left side, the same muscle on the left side, but the blue left side is being irritated, so you can see more activity, and the right side is more quiet and no abnormal firing, no spikes there. And the EMG can be done by 2 ways. One is spontaneous, one is trigger. Spontaneous is that we are not doing anything, we are just passively recording, and you're looking at just like this screen. So you're looking at this picture, the abnormal firing. The evoked or trigger EMG is you have a probe, and we stimulate with electrical current, and we look for the response there. So if you have a response, that means the connection is working, and depending what we are doing. Like for pedicle screw stimulation, so when the surgeon is placing the pedicle screw, the screw should be in the pedicle, but if they are out, and then response, when you stimulate the screw with the current take longer, much higher, because of the bone around the screw. But if there is a breach or break in the bone, the current always take the path of least resistance. So that will result in low current response at low current. So if you have response at low current, then we know the patient has a breach bone, and that screw has to be removed, otherwise patient will wake up with some deficit. For the hearing testing, preservation of hearing, we do auditory evoked potential, or BAEP, brainstem auditory evoked responses, and it is done to prevent any damage to the cochlea or cranial nerve 8 or brainstem, because we have different waveforms by 1, 2, 3, 4, 5, 6, 7, and that when we stimulate with the auditory signal in ear, the signal travels to the nerve, to the brainstem and cortex, and we have multiple recording sites, and we know we can identify the changes in cochlea or cranial nerve or a brainstem, and if there's a change, we can give them immediate feedback to the surgeon and minimize any damage. So all these different modalities, and there are other modalities which I have not mentioned here right now, but it was in the first list, like BEP and TCD and other things. But we don't do all the modalities all the time. We focus on what is the structure at risk, what structure is. So if it is the auditory signal, if the auditory nerve is at risk and facial nerve is at risk, so we do auditory evoked potential, we do EMG from the facial nerve, we do trigger EMG from the facial nerve, we do motor evoked potential or corticobulbar MEP, and then we do SSP for brainstem and the EEG for brain, and regular MEP for brainstem. So if it's spinal cord, then we do just sensory evoked potential, motor evoked potential, and EMGs trigger and spinal. So a multimodality approach is always better, because each modality has its limitation. The sensory pathway can only tell you about sensory pathway. It cannot tell you about the motor pathway or auditory pathway. but when we combine all of them, then we get the best benefit to the patient. The other modality is EEG or electroencephalography, which is continuous recording of the brain activity from SCAP. It is very helpful for measurement of cortical perfusion when the brain is at risk for having ischemic changes. For carotid surgery or brain surgery or aneurysm surgery, we can monitor the EEG during surgeries and minimize or identify the changes and inform the team. It can also be used for identifying the measurement of depth of anesthesia. How deep is the anesthesia? Is patient getting lighter or very deep during surgery? For the motor evoked potential, then we have another technique, which is D waves or direct waves, which is recording directly from the epidural space, and this is typically done for intramedullary spinal cord tumors above T9 level, thoracic level 9, because below that the conus is smaller, so you cannot record them. So it gives us continuous information, because motor evoked potential cannot be done very quickly because of the patient movement. So, but D waves are single pulse stimulation, so we can do every second, every 2 seconds. And if there's a change in D wave, then we can switch to the MEP and do that. So D wave is not done alone, but it's always done in combination with MEP and other modalities, and it is to minimize kyphoscoliosis. So that's some complicated cases where, like, this is one of my case where patient have kyphoscoliosis, and we published this paper in 2011. So a patient with Ehlers-Danlos syndrome or EDS will have much more risk because you're doing vertebral VCR or vertebral resection. So these patients are at risk. So monitoring of sensory evoked potential, motor potential is very, very critical in some patients. Selective dorsal root rhizotomy is another technique modality which is done for treatment of patient with cerebral palsy. So patient with cerebral palsy will have severe spasticity. So what we do, we identify the dorsal root, and then we split the dorsal root into multiple rootlets, and we stimulate each rootlet and identify which rootlet is have poor connection, and just cut the bad rootlet. So we don't cut the normal. If we are not doing the neuromonitoring, then the surgeon has to just cut the 30 or 50%, 30% of all the roots, and we may end up cutting the good root and leaving the bad rootlets, because we don't know which neurons were cut. But with the trigger EMG and SDR stimulation, we can identify the fibers which have more worse than the other, and cut selectively. So that's selective. Lipoma surgeries, they are again tumors of the fatty tumors of these patients have lipomyelomyelangiosis. So sometimes they have scoliosis, and they have tethered cord or split cord, but the phylum is attached because of their neural tube defect. So their meninges, they are not fully closed. So the phylum terminal can be anywhere. So we can identify by trigger EMG, like this picture. So we are stimulating, the surgeon is stimulating with a probe and holding this thick phylum. So this is a fatty phylum, which is very thick, and sometimes it's so thick that it is same size as the spinal cord. So it's very difficult to identify and cut that, because you are maybe risking cutting the spinal cord. So yeah, doing the trigger EMG, so it makes it easier for identification with the neurophysiological monitoring, because if you stimulate the phylum, you don't get response, but when you stimulate the nerve fiber, then you get a good response if the patient is not paralyzed. So we have to make sure there's no muscle laxance, so the muscles are working there. Now we have a special electrode which is used for measurement of responses from urinary bladder. In the past, urinary bladder monitoring was done in a clinical setting, but not in the operating room, because we did not have an electrode, and we were doing anal sphincter EMG and MEP for pudendal nerve, but there's a still risk of patient waking up with a urogenic bladder. But now we have this electrode, and which is stamped and come in Frank size 6, 8, 12, 10, 12, 14, 16, I think 18 too. So the size Frank 6 is the monopolar, but all the other are bipolar. So you can get a good recording. So these are the trigger EMG and MEP recording we used and published this paper.